In fact, Dr. Umesh and myself have done a few cases because of this connection that we have with spine and functional neurosurgery getting together in one platform. It was very interesting to have Dr. Balmurali talk this exoskeleton before I spoke on paraplegia, because this is going to answer many of the questions that has been raised as to how can a zero power person use an exoskeleton. Will it help in using the exoskeleton? Number one. Is a patient ready for exoskeleton usage? There's something called gyropotential generation of power. So your battery can be generated by the muscle itself, by getting the muscle to work. There are new devices that have got a sort of charging mechanism within the exoskeleton itself. So for all that, the main thing is we need the muscle power. How to get this muscle power. So this is what we have done with a small experience of 12 patients that I would be talking to you about dorsal column stimulation for paraplegia. So I think, next slide. So quickly going through a few slides. Paraplegia is due to spinal cord injury, has very high morbidity and mortality, as we know. We've seen many of these patients suffering really badly. The incidence of spinal cord injury is about nearly 10 to 56, 5.6 million per year. Motor vehicle accidents are the most common causes, and males are more, male is to female ratio is about 1.6 is to 1 to 13.5 is to 1. So 71% of them are in the age group, the 20 to 40, the maximum productive age group. That's where you have this. So it's a economical loss for the for this country too. Spinal column stimulation is by far a very, very useful neuromodulating modality. And there has been scientific evidences to better, to compare these modalities. We do have, in pain, we've seen how well it works in pain and other disease situations. In fact, stimulation of the spine had started years back, and it was after the, the Wall and Melzack's theory of gait control, the pain, stimulation for pain, it started in the 50s, late 50s and 60s. And with the advent of newer technology and better equipment, the better designing of the electrodes, a lot of nice indications have come out from neuromodulation of the spine. Indications of spinal cord stimulation accepted are, of course, with pain, chronic back, failed back syndrome, chronic regional pain syndrome, peripheral vascular disease to a certain extent, ischemic heart disease. So these are the indications. The controversial indications are, of course, post-herpetic neuralgia, diabetic neuropathy, and deafferentation pain in the cord. And a trial is the paraplegia. So paraplegia work is going on for about 5-6 years, and we've come to know many advantages with spinal cord stimulation where it comes to motor activity. It was always a sensory and pain, but now with the motor activity, we've been able to get some workload going on to the lower part of the spine and activity. So these are the absolute contraindications and the relative contraindications. Coming to paraplegia, we don't have a theory behind it. There's a lot of explanations. One of the commonest accepted explanations is the interneurons at the lower level of the spine, the lower dilatation of the spine, the conus region, have poly and monosynaptic connections, and these we are able to modulate these neurons to cause locomotion. So this is a spinal level locomotion with no cranial support whatsoever. Unless, I'm talking about zero grade paraplegics, unless there is a brain-computer interface which bypasses the segment which has been in the spine. So why did we think of spinal cord stimulation? So When patients came to us, these were international patients from Iraq and other places, they came to us for stem cell therapy. And these people, we didn't believe in stem cell therapy at that point because we've not got any evidence, and we've had patients who from in other sources who have come with stem cell therapy and been very, very unsuccessful. So we said we would do that same, we would do a type of treatment modality which would be cost the same, but has a little more scientific data and a little more scientific reasoning. So we had then, so I did only few patients, they were international patients to start with who had come for stem cells. And so these were the literatures that supported us. These are papers which had come in the early 20s, and we've seen with Susan Harkema, who was a pioneer in this. So she had a few papers, and they were all single cases. So we thought, based on that, we would go ahead with using spinal cord stimulation for people who are affordable and who want stem cell, and they've come with the money that is required for stem cell. So the selection criteria after we went through the literature were patients with more than 1 year insult to the spinal cord. It doesn't matter the extent to which. It has undergone all the physiotherapy and the conventional treatment for improvement of power. And then the patient and attenders, they have to be detailed and explained that this is not magic. We're not making him going to run in an Olympic or something like that. But we will help him improve his muscles to an extent that probably hip stabilization and of the muscle to a certain that would make him ready for maybe an exoskeleton that would come in the future. So that was what we had told them. Many of them had bed sores, so that was treated completely with, so the patients were fit for surgery. So this is an example of an MRI, and you can see here clearly that there was an injury here and there was implants put there, but the conus looked very healthy and size-wise quite good. So for such patients, initially we did MEP and nerve conduction study, and you can see we didn't get any firing here. But so the conclusion was the nerve conduction study showed bilateral femoral nerve motor axonal loss, secondary demyelination, bilateral common peroneal. So the whole thing was assessed, and then there was some innovation in the L2 to S5. So we patient up, and this was a surgical modality. We had marked D11 to L1. The laminectomy was done either by an MIS or open. So initially we did with MIS because that was easy, and we were then we had to change. I'll let you know why. And we had good response while we put the electrode in and stimulated intraoperatively. So we did stimulate intraoperatively to find out that we are in the right position. So this is the case one where the patient had a road traffic accident about 5 years back and had come to the hospital after 1.5 years of injury. And this is what we did. We marked the D11 area. We put in a tubular retractor, and a D11, D12 laminectomy was done at that point, and the electrode was passed sublaminar all the way up to the D11, DL1 junction. So you can see it's at the lower border of DL here, and covering D12 and up to about L1, the conus region. So this is how the surgery was done, and here we got some response while stimulating intraoperatively. We had the foot dorsiflexion while stimulating, and that was the only thing we had checked at that point. And then so this is the patient before switching on the battery. You can see he couldn't move his limb at all, though his hip stabilization was good, but you can see very clearly that the limbs were just dangling. So this was about this is about 1 month later. You can see he's able to lift the foot. So his muscles had improved, his thigh muscles had improved. And this was 6 months later. All this while he's having intense physiotherapy. We have a very good physiatrist who does the programming. Again, details of which I will let you know in the following. So this is how he's able to move. 10 months later, he was able to cycle with support. This is 1 year later. With support, he's able to walk. 1 year, 2 months, 1 year, 6 months, and 1 year, 8 months, he was able to walk with support. So at this point, he's probably a good candidate for an exoskeleton. Because he's been trained, his muscle has been trained, he's able to do the initial movement of walking, and probably he would be ideal for being exoskeleton. So this is the second case, again, paraplegic since 3 years, and this was his pre-operative, absolutely not able to move. This is 1 month later, he's able to flex without gravity. 3.5 months later, he was able to stand with support. So here his hip stabilization was very important. And 7 months later, and a year later, he was able to cycle. Now it's a year and 3 months that he is in Iraq, he's able to stand. So he is now again a person would be ideal for using an exoskeleton. Patient 3, again, this person had a fall from height and had D7 to D8 stabilization. This was 1 month later. You can see how he's able to move his limbs. But unfortunately, this patient was lost to follow because he went back to Yemen. He was from Yemen, and we didn't hear from him later. So after all these experiences that we had with 2-3 patients, we then met Dr. Susan Harkima, and then with her, we have signed an MOU, and we are planning to do a collaboratory work, and we've changed certain modalities of how we do surgery. So the recent experience we have, these are things that we do. One is we have a MEP connected to all the muscles. We have all the muscles connected, and then open laminectomy, and each of the nerves are stimulated without the implant in to find out the frequency and where exactly they lay. And then we place the electrode in the same place, and we hitch the electrode so that does not move. And we get a lot of information intraoperatively as to which group of muscles can be stimulated and are stimulatable using an MEP. So this is the intraoperatively when we plus. This is how the electrodes are put and placed, and then we have a programmer by which we are able to decide which are the groups, because it's a 16 electrode, 16 contact electrode, so we know where to use what and how to go about that. So we have the patient programmer like this. So these are the electrodes that we use, and how much of positive, how much of all these, which of these electrodes correspond to which group of muscles, we're able to decide intraoperatively. And then, so we understand the physiology much better before we start the next programming. So this is what we got. For flexion of the left knee, we had this combination. For the right, we have this. For the left extension, this. So all these permutations and combinations were used to further teach the limb in inverted quadrants, teach the lower limb to start walking. And here we have 1 month. This was the first Indian patient that we did. And in 6 months, she was able to walk with support. Now she is also probably ready for an exoskeleton. So this is another patient, you can see. She was a gynecologist from Africa, and she came, and the good thing about her is her bladder function also improved with dorsal column stimulation. And she, in fact, is a person who keeps sending patients from Africa for this, and we've got a large number of patients being able to come because the doctor herself is recommending. She was totally bedridden. She had bed sores when I had visited her in Ethiopia. This is how she was on bed, no movement at all. And now she's 2 years post-stabilization, she is able to go. Again, she is due for probably exoskeleton. So I think same thing goes on. This is, nowadays, this is one done last month. And he was 0, and now he's able to flex. So we are getting better activity now and faster because of the more detailed intraoperative examination. So this is our demography. I think a shortage of time. I'll just go quickly. So the most important thing about spinal cord neuromodulation is we are there to stimulate these muscles, and at the spinal level, there is some physiology that works and local locomotory fields work, and then they have this. So it's a still learning curve. I think we have to combine with exoskeleton and then make this dorsal column stimulation very beneficial. Our first patient now walks with support without a stimulator because the spinal cord has learned how to do it. So he's probably ready for exoskeleton. Thank you so much.